Today we are going to briefly talk about skin malignancy. A 42-year-old gentleman visits the dermatology clinic complaining that a mole on his left forearm has changed shape, enlarging to almost 0.5 centimeter in diameter. The part of it has now become very dark black, although it was previously homogeneous in color. He has no significant past medical history but states that he uses tanning beds frequently and has spent few years of his life in New York. Investigations were essentially normal without any abnormality. ESR is normal. Excision biopsy shows 5 millimeter thick lesion with no ulceration. Which one of the following features is most commonly associated with poor prognosis of this gentleman? So going back to the history, a mole which has changed in shape, which have changed in color, and it's almost 0.5 centimeter in diameter. So the diagnosis is probably a melanoma. And the diagnosis and the biopsy shows 0.5 millimeter thick lesion. So which one of the following features mostly associated with poor prognosis? Significant exposure to sunbeds, lack of ulceration, depth of melanoma, his age, male sex. Out of these options given, depth of melanoma is the single most important predictor for melanoma outcome. So the correct answer will be C. Survival is strongly correlated with depth of the melanoma at the point of diagnosis, with lesions over 4 millimeter thick being associated with particularly poor outcome. Other predictors of poor outcome include age and male sex. Ulceration of lesion also implies greater risk of metastasis. For lesions of 4 millimeter thick with ulceration, 5-year survival is less than 50%. So important predictors will be Breslau's thickness, ulceration, mitotic rate, lymph node biopsy result, extent of lymph node involvement, presence or absence of distant metastasis. So melanoma, you all know, is very significant disease and important cause of mortality. There can be various kinds of melanomas. It can be superficial spreading. There can be nodular form. Can have lentigo maligna. Then you have acral lentiginous melanoma and amelanotic melanoma. So dermoscopy, histopathology, we look into Breslau's thickness, immunohistochemistry, we look for BRAF antigen, sentinel lymph node biopsy, radio imaging. And for stage 1 to 2A, it's resection. More than stage 2B, surgery plus minus chemotherapy. Then we have immunotherapy, targeted therapy for BRAF, and chemotherapy with dacarbazine. I'll talk a little bit more about this treatment. So Breslau's thickness is it's measured from the granular layer, from measurement of the granular layer to the deepest part of the melanoma. This is known as Breslau's thickness. And as I already mentioned, if it is more than 4 millimeter, the mortality is 50%. And the histologic findings include cytologic atypia, enlarged cells containing pleomorphic hyperchromic nuclei with prominent nucleoli. You get numerous mitotic figures, and you have pagetoid growth pattern with upward growth of the melanocytes. So these are all histopathological features of melanoma. So dermoscopy, I mentioned histopathology, mainly excision biopsy. Staging of the disease is mainly done by sentinel lymph node biopsy, and considering the stage, the whole body and brain contrastivity for people who have more than stage 2B melanoma. Offer staging with whole body and brain MRI instead of CCT to children and young adults with stage 2B to 4 and women with stage 2B to 4 melanoma who are pregnant, and in patients with 3C and 4 with mitotic index more than 5 and patients of scalp melanoma. So these are the patients where you will go for MRI. This is the NICE guidelines. Assessing melanoma, if targeted systemic therapy is a treatment option, for genetic test using a secondary melanoma tissue sample if there's adequate cellularity, or a primary melanoma tissue sample if secondary sample is not available or is inadequate. BRAF analysis of melanoma tissue samples with people with stage 2A, 2B, or carry out BRAF for 2C to stage 4. So consider analysis in these two stages, whereas you always carry out to stage 3 to 4. If BRAF 𝑨𝒃𝒐𝒖𝒕 immunochemistry is negative or inconclusive, you can use other BRAF genetic testing. So these are again nice guidelines. So surgery, medical management, you can have adjuvant therapy in form of immune therapy, and in unresectable melanoma, you can again offer immunotherapy, chemotherapy, and radiation. Dabrafenib and trametinib for adjuvant treatment for resective BRAF 𝑣600 mutation positive melanoma. Pembrolizumab for adjuvant treatment of completely resected stage 3 melanoma. Nivolumab for adjuvant treatment of completely resected melanoma with lymph node involvement or metastatic disease. These are according to NICE guidelines, and you should remember these treatment options. So these are various agents that are used for immunotherapy I've listed, but the one which I've highlighted are used in UK, and dacarbazine is the most common chemotherapeutic agent used for melanoma treatment. A 30-year-old gentleman presents to clinic with concern regarding a mole on his face. Which one of the following characteristic of the lesion would raise suspicion that it's a malignant melanoma? The lesion is ulcerated, lesion is present on face, lesion is pigmented uniformly, the lesion has regular age, the lesion is 5 mm diameter. So among these options, the suspicion will be suspicious when the lesion is ulcerated. The ABCD mnemonic is very important. Asymmetry is one half of the lesion does not match with the other half, that is asymmetry. Border irregular. Color variegation means somewhere it's light, somewhere it's dark. So the pigmentation is not uniform. And actually dermoscopy can help you to determine the pigmentary changes very nicely. D is the diameter. 7 mm warrants investigation, although changes in size are also important. Evolution, evolving size or changes in characteristics such as nodules. So A, B, C, D is the most important thing. But in this patient, ulceration is also another important sign of suspicion. A 42-year-old gentleman following visit with pulmonology clinic complains of mole irregular outline on the right side face, and he has noticed few weeks ago. Which one of the following characteristics of the lesion would raise suspicion that it's a malignant melanoma? Lesion is deeply pigmented, irregular outline, 5 mm diameter, lesion raised, present on face. Again, out of the options, this irregular outline will be something which should again raise suspicion. Again, this is A, B, C, D, E, which comes into picture, and you have to justify the answer. A 56-year-old gentleman underwent renal transplant 7 years ago and on cyclosporin since then. He now presents with small hard lesion on the side of his head. It has brown irregular border with central hard area. So a renal transplant patient presents with small hard lesions on the side of his head with irregular border and central hard area. Which is the most following diagnosis? Actinic keratosis, squamous cell carcinoma, malignant melanoma, basal cell carcinoma, seborrheic keratosis. Now, from the options given, it is a bit difficult to differentiate between this actinic keratosis or transplant patient with an non-resolving lesion, which is hard and irregular border. So probably points towards some skin growth. Whether it's actinic keratosis or squamous carcinoma, malignant melanoma on basal cell carcinoma, seborrheic keratosis, melanoma will be pigmented. Basal cell carcinoma, usually a very indolent lesion, Seborrheic keratosis will have some warty surface. So actinic keratosis also presents usually scaly patches, but it should not be hard, and it shouldn't. Border can be irregular, but it shouldn't be hard. So the most possible diagnosis is squamous cell carcinoma. Long-term immunosuppression, for example, cyclosporin can predispose patients to patients with autoimmune disorders or transplant patients to infection and malignancy. The most common malignancies are squamous cell carcinoma, basal cell carcinoma. The description classically fits with squamous cell carcinoma. Basal cell carcinoma classically occurs in face or in sun-exposed area and have red, pink, or pearly in nature. It can also ulcerate. Malignant melanoma, usually irregular, pigmented, growing mole that may be symmetrical and show worrying features like bleeding. Seborrheic keratosis, a benign keratinized burst, sign of skin aging. Actinic keratosis, a dry precancerous skin changes associated with sun exposure. So this is risk of renal cancer in renal transplant patients. Among skin cancers like squamous cell carcinoma, basal cell carcinoma, there can be melanoma, high incidence of Kaposi sarcoma has been reported. And of course, there are other organs which can also develop malignancy. Especially lymphoma proliferative disease has been associated with cyclosporin. And these are a few precancerous skin lesions. Actinic keratosis is actually a precancerous lesion. Chronic radiation keratosis, Bowen's disease, erythroplasia of Queret, erythroplakia, leukoplakia. These are all pre-malignant lesions. And biopsy is needed in all these patients. Thank you very much.